Start. Welcome back, guys. Now let's discuss the topic of collecting ducts. Okay, collecting ducts. Now these collecting ducts are the last parts of the nephron. Okay. Now these collecting ducts are mainly divided into how many types? Okay, the part of collecting duct which is present in the cortex. Okay. Now the part of collecting duct which is present in the cortex is called as a cortical collecting duct, and the part of collecting duct that's coming down into the medulla is called as medullary connecting duct. Okay, so collecting duct is of how many types? Just based on the placement, based on the position. So cortical collecting ducts as well as the medullary collecting duct. Two types are there. The point is, now how many types of cells are there? Doesn't matter whether it is cortical collecting duct or medullary collecting duct, not matter. See, there are two types of cells present in this collecting duct. So what are the two different types of cells? The two types of cells are principal cells and intercalated cells. So principal cells and intercalated cells are the two types of cells in the collecting ducts. Okay, now two types of cells are there. Now on these two types of cells, or I should say on this collecting duct, two types of hormones are going to act. So what are the two types of hormones which are acting on the collecting ducts? The two types of hormones are aldosterone. Okay, aldosterone we'll discuss, don't worry. Okay, aldosterone and antidiuretic hormone, which is also called as vasopressin. So aldosterone and antidiuretic hormone are the two types of hormones which are going to act on the collecting ducts. Okay, now after this, let's start with the topic of aldosterone. Let's start with the topic of aldosterone and we'll go one by one. First aldosterone, later antidiuretic hormone, okay, and related clinical disorders we will see. Now, aldosterone. See, aldosterone is an example of, first point is aldosterone is an example of mineralocorticoid. Okay, it's a mineralocorticoid. Now, point is, this aldosterone, it is coming from where? Okay, aldosterone is produced from, we all know, aldosterone is produced from adrenal gland. From which part of the adrenal gland? Aldosterone is coming from zona glomerulosa. Here is the zona glomerulosa. Now this zona glomerulosa, whenever it is stimulated by angiotensin II. So whenever angiotensin II stimulates the zona glomerulosa, now this zona glomerulosa is going to release aldosterone. ALDO, aldo. Okay. Now this aldosterone, it is coming. Okay, it's coming. To where it is coming? It is coming to pre-CT. Now we are talking about the collecting ducts. Now aldosterone, say it is coming like this. Aldosterone is coming. So now here is the aldosterone. Point is, aldosterone is a steroid. Okay, it's a mineralocorticoid, though it's a steroid. Okay, it's a steroid. Now what does I mean by steroids? Steroids are the hormones which are derived from cholesterols. So anything which is derived out of cholesterol, yeah, they can simply cross the lipid membrane. See this aldosterone, now it is crossing the lipid membrane and it's entering into the cell. Now the receptor, my question is, the receptor for this aldosterone is present where? The aldosterone receptor is present in the cytoplasm. See, here is the cytoplasm. Now, see, this aldosterone is acting on the cell. It is crossing the cell membrane. Now, it is coming and binding to its receptor which is present in the cytoplasm. Okay. Now, my question to you. So, this aldosterone is going to act on principal cells or is it going to act on the intercalated cells? Now, we have seen, right, in the previous slide. See, now the aldosterone, yeah, it will act on principal cells or will it act on intercalated cells? See, this aldosterone, it will both act on principal cells as well as intercalated cells. Okay, so aldosterone, it acts on principal cells, see, it acts on principal cell as well as it will also act on the intercalated cells. Okay, now my point is, whenever aldosterone is acting on the principal cells, what happens? Now this aldosterone, it will go and bind with the receptor. Now this aldosterone receptor complex, okay, now this aldosterone receptor complex, now it will go into the nucleus. It will activate the transcription factors. Okay, it will activate the transcription factors. So whenever the transcription happens, later translation will happen. So at the end of the day, new proteins are synthesized. So under the influence of aldosterone, new protein channels are being synthesized. New proteins are getting synthesized. Now what are those new proteins? Now these proteins are nothing but channels. Now which channels? Now these channels are called as ENaC, epithelial sodium channels. Okay, ENaC, epithelial sodium channels. Now, what is the function of this epithelial sodium channel? Under the influence of aldosterone, only whenever there is aldosterone. Now, in that condition, yes, these channels are produced. Now, what these channels are going to do? Now, they will reabsorb the sodium. So, aldosterone helps in reabsorption of sodium. Okay, so that's why sodium is a mineral. So, mineralocorticoid. Aldosterone helps in reabsorption of sodium into the body. Now, the sodium, it's a positive charge, right? It's a positive charge. When the positive charges are coming into the cell, now in order to maintain the electron neutrality, you need to take out the extra positive charges out of the cell. So sodium is coming into the cell. So in order to balance, one potassium ion will leave the cell. So for the entry of sodium, potassium is leaving out of the cell. So I can clearly say aldosterone helps in sodium reabsorption At the same time, aldosterone helping in potassium secretion. So potassium is now going into the urine. One function is completed, sodium reabsorption, first function, and the second function is potassium secretion. Okay, done. So two functions of the aldosterone are completed. So all these two functions, okay, both these two functions are happening in the principal cells. Okay, now when this aldosterone, when it acts on the intercalated cells, what will happen? Now when the aldosterone, when it acts on intercalated cells, they will throw the protons. See, protons are being pumped into the urine. Okay, with the help of ATP, protons are being pumped into the urine. So aldosterone helps in sodium reabsorption, potassium secretion, as well as proton secretion. So what are the three important functions from now? Okay, even in your sleep you should know this thing. Aldosterone having three functions. What are the three functions? Okay, let me write it down here. Aldosterone have three functions. What are the three functions? Sodium reabsorption, potassium secretion, proton secretion. These are the three functions. Okay, now let's see one by one important points. Aldosterone, okay, mineralocorticoid. Okay, sir. It helps in what? Sodium reabsorption. Now aldosterone, where it is produced from? It is produced from zona glomerulosa of adrenal gland. Now this aldosterone is going to act on principal cells or intercalated cells? See, acts on both principal cells as well as intercalated cells. Now what is the stimulus? Okay, what is the stimulus for the release of aldosterone? The major stimulus, see, already we have seen one stimulus. Already in the RAS pathway we have discussed. The stimulus for the aldosterone release is angiotensin 2. Okay, but if they ask you what is the major stimulus? Major stimulus is hyperkalemia. Hyperkalemia is a major stimulus, which means if you have more potassium in your blood, that is hyperkalemia, which will cause arrhythmias, which will trigger the arrhythmias and can kill the patient. So now potassium hyperkalemias stimulate the release of aldosterone. Okay, hyperkalemia stimulate the release of aldosterone. Now what this aldosterone will do? See, aldosterone is taking the potassium out of the body, potassium excretion or potassium secretion. So potassium is going out of the body. So whenever you have more potassium in the body, aldosterone is going to come. This aldosterone is going to take the potassium. It's going to throw the potassium out of the body. Okay. So major stimulus is hyperkalemia. Not only that. Okay. Not only that, even angiotensin 2 will also stimulate the release of aldosterone. Now see here guys, aldosterone, yes, it acts on the principal cells as well as it acts on the intercalated cells. Now if it acts on the principal cells, what is happening? Sodium reabsorption. When sodium is reabsorbed, along with the sodium, some amount of water will also be reabsorbed. So sodium reabsorption followed by water reabsorption. Not only that, in exchange for sodium, potassium is going to be secreted or potassium is going to be excreted. So all these are happening in the principal cells. Now in intercalated cell, now protons are excreted or protons are secreted, throwing out of the body. So these are some important points regarding the aldosterone. Okay, now also I have explained to you steroid receptors, like the steroid hormones like not only this aldosterone, even glucocorticoids, okay, which are steroids, even sex corticoids like testosterone, estrogen, progesterone, dihydroepiandrosterone, androstenedione. Now these are all this all these hormones. Now all these hormones, which are the steroid hormones, they have the intracellular receptor. The receptors are present within the cell, not on the cell membrane. Already discussed with you. Now principal cells, yeah, see, principal cell, aldosterone is going to act on the principal cells. Even in the principal cells, the aldosterone have cytoplasmic receptor. The receptor of the aldosterone is present in the cytoplasm. Already discussed. Now here, important point is, see, the channel which is reabsorbing the sodium. The channel which is reabsorbing the sodium is called as epithelial sodium channels. Already discussed. Now point is the channel which excretes. Okay, the channel which excretes the potassium out of the body. Now this channel is called as ROMK channels. Okay, ROM for renal outer medullary potassium channels. So renal outer medullary potassium channels are trying to secrete the potassium out of the body. Okay, so these are some important points. Now after this, let's have some clinical integration. Okay, so now what is the clinical integration? Now this epithelial sodium channel, see, ENaC, epithelial sodium channel, this fellow, okay, sodium reabsorption. Now the epithelial sodium channels, they are under the control of what? They are under the control of aldosterone. So whenever there is aldosterone, now aldosterone helps in production of epithelial sodium channels. Epithelial sodium channels reabsorb the sodium. Okay, this is a normal story. But if the epithelial sodium channels are continuously working, means even without aldosterone influence, even without aldosterone, think that aldosterone is not there. Whenever the aldosterone is not there, the epithelial sodium channels should be degraded. Okay, whenever there is aldosterone, epithelial sodium channels should be there and they have to reabsorb the sodium. But whenever aldosterone level goes down, whenever there is no stimulation from the aldosterone, these epithelial sodium channels, they need to be degraded. They need to be degraded. But because of some mutation, now these epithelial sodium channels are not getting degraded. Now these epithelial sodium channels, what they are doing? They are continuously overaction they are doing. They are continuously reabsorbing the sodium into the body. So this syndrome is called as overactivity of the epithelial sodium channels. Okay, ENaC overactivity will cause a syndrome which is called as Liddle syndrome. Okay, Liddle, not little, Liddle syndrome. It just looks like little, but it's not little, it is Liddle, which is autosomal dominant. Okay, Liddle for dominant, AD. Okay, so previously we have discussed the Bartter syndrome as well as the Glickman syndrome. They are autosomal recessive disorders. Now this is Liddle syndrome, it is autosomal dominant. Now, what are the clinical features which are going to be seen in this Liddle syndrome? You think logically, guys. Okay, now even without aldosterone, epithelial sodium channels are working more. Okay, now what happens? More and more sodium is going to be reabsorbed back into the body. Now more and more sodium reabsorption happens means what happens? Hypernatremia. Like the patient is going to have hypernatremia. That hypernatremia is going to cause hypertension. So the clinical features are hypertension. Why? Because epithelial sodium channel overactivity, more sodium reabsorption, that causes hypertension. Now whenever there is hypertension in your body, what happened to the RAS pathway? RAS pathway is inhibited, remember. So if you have hypertension, RAS pathway is inhibited. Why? Because normal function of the RAS pathway is to increase the BP. RAS pathway is going to be activated whenever there is hypotension. Whenever there is hypotension, RAS pathway is activated. Or whenever there is beta-1 adrenergic stimulation, RAS pathway is activated. But now see, hypertension is there. Now this hypertension will inhibit the RAS. Whenever the RAS pathway is inhibited, what happened to the angiotensin 2 levels? Angiotensin 2 levels decreases. What happened to the aldosterone levels? Aldosterone levels decreases. Angiotensin 2 levels are less. Aldosterone levels are less. What happened to the renin levels? Okay, what happened to the renin levels? Renin levels also decrease. Okay, so renin levels decreases, angiotensin 2 level decreases, aldosterone level decreases. So even without aldosterone, now epithelial sodium channels are overactivated. Okay, now they are over functioning, more sodium reabsorption. Now we all know aldosterone, what it will do? It will throw the potassium out of the body. Okay, it will excrete the potassium out of the body. Now here in this condition, what happened to the aldosterone? Aldosterone is not there. Okay, the aldosterone is not there. But see, more and more sodium is getting reabsorbed. Now more and more sodium is getting reabsorbed. Now whenever the more sodium is getting reabsorbed, what happens? Okay, more potassium need to be excreted out. Okay, more potassium need to be excreted out. See, more and more sodium is getting reabsorbed. If more sodium reabsorption, okay, more sodium reabsorption, more potassium need to be excreted out. So more potassium means the patient is going to become hypokalemic. Okay, hypokalemic. Simple concept. Now this epithelial sodium channel, it is overactivated. Now if it is overactivated, more sodium reabsorption. So more positive charges are coming into the cell. If more positive charges are coming into the cell means in order to maintain the electron neutrality, more positive charges need to go out. So more potassium is excreted out. So what happened to the potassium levels inside the body? The potassium levels inside the body are getting decreased. So hypokalemia. Okay, hypokalemia. Okay. Not only that, now even in the intracalated cells, more potassium, okay, is going to be more protons, I should say, more protons are going to be excreted out. You can ask me why more protons are getting excreted out, sir. Usually, please look at here. See, the potassium, okay, this potassium, okay, is going out, right? The potassium is now secreted here. Now, some amount of potassium will try to come back. Okay, some amount of potassium will try to come back. Now, in an attempt to reabsorb the potassium, okay, more protons will go out. If you want to reabsorb the potassium, you need to throw the protons out of the cell. So now what is happening in the Liddle syndrome? Simple. In Liddle syndrome, sir, more sodium reabsorption. Okay, more sodium is getting reabsorbed. In order to reabsorb the sodium, more potassium need to be excreted. So more potassium is getting excreted. Now this potassium will try to come back into the body. Now in an attempt to come back into the body, yes, see, potassium is coming into the body. In that process, more protons are going out of the body. So that causes what? Even alkalosis. This patient is having alkalosis, hypokalemic alkalosis. Okay, so more potassium is going out of the body. Some potassium will try to come back. Now in that attempt, more protons are going out of the body. That causes hypokalemia as well as alkalosis. Hypernatremia causes hypertension. Okay, so more potassium excretion will cause hypokalemia as well as alkalosis. Okay, now this patient, do you think more dehydration is there? No. In Bartter syndrome and Glickman syndrome, please remember, in Bartter and Glickman syndrome, the neonates, They are having sunken anterior fontanelle, polyuria, dehydration, failure to thrive. But such kind of problem is not there here. Why? Because see, more sodium reabsorption means what happens? More sodium reabsorption means more water reabsorption. The patient will be having water overloaded state. Okay, water overloaded state, not the dehydration. So dehydration is not seen. Okay, now what you need to do? All the problem here is because of this one channel. Okay, this one stupid channel which is overactivating. What is this channel? Epithelial sodium channel. You need to simply block that epithelial sodium channel. So epithelial sodium channel blockers are the drug of choice for the treatment of Liddle syndrome. Now, what is the example of this epithelial sodium channel blocker? The name of this epithelial sodium channel blocker is amiloride. Okay, so amiloride is a epithelial sodium channel blocker which is used in the treatment of Liddle syndrome. So now tell me, in Liddle syndrome, okay, aldosterone levels are what? Aldosterone levels are less, okay, or reduced due to inhibition of RAS pathway. RAS pathway is going to be inhibited. Okay, now see, if you get a question, hypertension with hypokalemic alkalosis. Hypertension is there, more BP, hypokalemia as well as alkalosis. So it is seen in Liddle syndrome. Hypertension with hypokalemic alkalosis is seen in Liddle syndrome. Why? Because in Bartter syndrome, BP is never increased. In Glittman syndrome, BP is never increased. Now, you will get it out. Sir, what is this Fanconi syndrome? Can anyone tell me? What is this Fanconi syndrome? See, this Fanconi syndrome is globalized defect of the proximal convoluted tubules. Okay, proximal convoluted tubule is there, right? Now in the proximal convoluted tubule, sodium reabsorption happens, like potassium reabsorption happens, sodium reabsorption, glucose reabsorption, amino acid reabsorption, bicarbonate reabsorption, so many things are happening. For example, now there is a defect in proximal convoluted tubule, all the channels, okay, all the transporters in the proximal convoluted tubule are not functioning. If they are not functioning, means what happens? Glucose is going to go out in the urine, glucose urea, amino acid urea, natriuresis, bicarbonate uresis, okay. So that is called as Fanconi syndrome. Fanconi syndrome means entire PCT, generalized PCT defect, where the reabsorption of the substances are not happening, everything is going out in the urine. Even, see, the PCT is the most important site for the water reabsorption. Okay, PCT is the more important site for the water reabsorption. 70% of the water is reabsorbed. Now, if there is a PCT defect, means water reabsorption is not happening. Okay, water reabsorption is not happening. So what happened? Water is going to go out of the body, diuresis. Okay, more water is going out of the body. So what happened to the BP? BP will be decreased. So even in Fanconi syndrome, the patient is going to have normal BP or even low BP, but BP is never increased. Now in our question, what they are asking? Hypertension. So hypertension is seen in Liddle syndrome, but not in the Bartter-Glittman or Fanconi syndrome. In all these three, okay, BP is either normal or even increased. Okay, so with this, we are done with the concept of Liddle syndrome, and also we have discussed about the aldosterone. In the next video, we will also discuss more clinical concepts about this aldosterone secreting tumors like Conn syndrome. Okay, we will discuss much more in the upcoming video. Hope the video is helpful. Thank you.